Thank you very much. Hello, everyone. Let me invite my extraordinary colleagues to join me on the stage. So, I want to thank the festival organizers. It's a privilege to be here. It's a privilege to be speaking to all of you. Welcome and good morning on this winter day in Jaipur. We are delighted to be here. We are going to talk about a serious topic. It's healthcare in India. As we all know, healthcare is a live issue all over the world. In the US, we are still debating what is sometimes called Obamacare. We're here today to talk about healthcare in India. And I want you to know that we have a brilliant plan for executing this conversation because we have 4 extraordinary people here, and then there's one simpleton, you're looking at the simpleton right now, who will ask the simplest questions to really get us going. So let me just introduce my colleagues. Let me start with Poonam Muttreja. Poonam Muttreja is the head of the Population Foundation of India. She has decades of experience in India and internationally in development. Next to her is Vikram Patel. Vikram is the Paul Farmer Professor and Chair of Global Health at Harvard Medical School. Next to him is Tarun Khanna. Tarun Khanna is a professor at the Business School. His work is in entrepreneurship, and he looks at it as a means of social and economic development. And last, but in fact, in this case, the most perhaps, is Richard Horton. Richard is the editor-in-chief of The Lancet, which is perhaps the world's premier medical journal. So we're going to talk about this report, and this is going to be a conversation. It's also a preview. We will launch the full report in New Delhi on the 21st at the Habitat Center. Please join us there if you would like. And I'm going to make this very simple, and maybe I'll start, Vikram, with you. And I'll say, Vikram, if this report is an answer, and we've been doing the research on it for several years, and you'll hear more about it from Vikram, what is the question that started you on this path?
Well, thank you, and thanks for showing up this morning to all of you. So this commission in The Lancet, and you're going to hear in a moment about The Lancet and what a commission in The Lancet means. We launched it in December 2020, and I'd like all of you to remember, most of us have tried to blank this out of our minds because it's a period of history which, interestingly, we have all chosen to rapidly forget. And yet it was only 5 years ago. This was, of course, at the end of the first year of what is the most cataclysmic health event in all of our lifetimes. The pandemic was already in its first year. We'd already begun to see the impact that was having on the health of our people, and that was still 3 months ahead of what was really devastating phase of the pandemic, in which anywhere from hundreds of thousands to millions of people, depending on whose statistics you believe, died in this country. So I want to actually maybe obviously, one of the big motivations was, why was our health system not fully prepared? To be fair, no health system was fully prepared, but we were living in India, this was our context, and we wanted to ask the question, why was our health system not fully prepared? But the question about our health system actually goes back for me to my own lived experience of my family, and maybe I'll do a little bit of a poll here. I just want to ask how many of you who live in India have sought care from any doctor or clinic for yourself or your family in the last year or two? Just show me your hands. So that's pretty much everyone in this hall, which is pretty incredible and tells you something that all of us are seeking healthcare. And maybe I'll ask another question. I can predict what, given the social demographic of this group, how many of you chose the private sector? Your hands. Well, almost everyone again. And let me ask you one more question then. How many of you left feeling that you had had a really great experience, that your doctor listened to you, and most importantly, that you didn't feel cheated at the end of that healthcare experience? How many of you? Show your hands. Pretty much about a half of you. And I think this is really the question that I think I have grappled with through watching my mother's long, epic journey with diabetes and feeling constantly that she received some good things, but also it could have been a lot better. And that was the kind of quality problem that I felt we needed to address.
Vikram, thank you. And in case I hadn't said it in the introduction. You can see he's a professor and a very good one, the way he did that. Let me turn Richard next to you. So this work was done as a part of a Lancet commission. So Richard, I have limited knowledge, and so that's always a dangerous thing. Tell us about the Lancet. I said it's the world's premier medical journal, perhaps. What is the Lancet, and what is a Lancet commission? Why was it relevant to this work?
Okay, thank you very much, Hitesh. Good morning, everybody. It's wonderful to be here at, in my experience of 30 years or so, definitely the world's best literary festival I've ever been to. It's a truly remarkable event, and it's great, just great to be here. The Lancet, we're a weekly medical journal, founded by a prickly and precocious 27-year-old in 1823. We just celebrated our 200th anniversary. And he was trained in medicine in London in the early 19th century and saw the degeneracy of English medicine at the time, and so created the Lancet so that it could lance, it could incise the abscess of nepotism and corruption in medicine, but also act as an arched window to let in the light of knowledge onto that diseased corpus of the discipline. He launched this journal. It was immediately successful. He was sued many times, and he wanted to use the journal not just as an instrument of knowledge, but as an instrument of political reform. And the task for every generation that's followed him of editors is to reinvent that idea of Thomas Wackley. So the commission, around 2008, 2009, we saw that the world was facing these incredibly complex challenges: climate, poverty. How were we going to address these? Well, the fact is, a bunch of doctors, the health sector alone, couldn't solve these complex problems on their own. We needed to have a multidisciplinary response, and so our first topic that we addressed was health and climate change. And we brought a group of experts, political scientists, geographers, economists, engineers, and a few doctors and health workers together, and we published our first commission. The idea being, and there's some shared values in all of the 100 or so commissions that we've published since 2009, the idea being that, first of all, health in our world has special moral importance, because without health, all other opportunities before us cannot be realized. Health is a prerequisite for almost everything else in life. And if you don't have health, then the doorways to your future become narrowed. Second, science. Science is one of the most powerful means for generating reliable evidence to guide our decisions. And third, and I think most importantly, especially in the context of this commission, we can all agree there are no such thing as utopias, but there are such a thing as a realistic utopia. And that was the phrase used by John Rawls in his 1971 book, A Theory of Justice. The idea that we can extend the limits of possibility in our world, that we can marry together the facts of the life around us with our ideals. And so what this commission on India does is to tell the story of a nation and to present a genuinely realistic utopia of what India could be if the recommendations were fully followed and delivered.
Thank you, Vikram. Yes, please. And in fact, your answer is making me turn to Poonam next, but I want to say there are no utopias. But since we're at a literary festival, I do want to say that when the poet Bedil first entered the court of the Emperor Shah Jahan, he exclaimed, "Agar bihisht dar zameen ast, hameen ast, hameen ast, hameen ast." If there be paradise on earth, it is here, it is here, it is here. But the import I want to take from your answer is the import of institutions that human beings have built to address the human condition. India is particularly rich in those. They go back to very ancient times. But let me come back to modern times. Poonam, you head a civil society institution. You've been involved in founding and leading many of them, both here and internationally. So what is the role that a civil society institution, and yours in particular, have had in this work?
So, thank you. I came to public health from working with women, working with poor, working with the marginalized, whose lives, as Richard said, there's nothing more important than health for their lives. And we found that India has a large public health system, infrastructure, but what is missing in the public health especially is the public. So the idea, I resonate with the Lancet Commission, is to reimagine India's public health from a citizen's point of view. And having worked with citizens across the country as part of the Community Action for Health program, which is one of the 5 pillars of the National Rural Health Mission, which was set up in 2005 and has made huge progress. But what is still missing is the citizen. And we were charged at PFI to do the Community Action for Health work, where we worked across the country, strengthening the institutions that the people's institutions, like the village health and sanitation committees, Rogi Kalyan Samitis, there are 500,000 of them across the country where there's opportunity for citizens to participate in the architecture. But what is missing is still citizens' participation, and especially holding, not just participation, but holding government, the public health program, accountable. If the private sector response was what Vikram asked, what it was in this room, think of the asymmetry in power in the public health system. And we have found where people have been able to hold governments accountable, whether it's in public health, education, and so on, the systems improve, they are more responsive to the lived realities of the people. And I especially want to mention women again. And in the case of women, the only in the average marginalized community, women get in contact with the frontline public health workers. And that's their entry into the health system and other systems. And given that the public health system does not respond to violence, which 70% of the women experience in India, and the recommendation, one of our recommendations clearly is to bring women into the public health, especially on violence. We're sitting in Rajasthan where 1/3 of women experience violence, and there is the fear women have and the lack of freedom to access public health facilities. And these are all the recommendations I'm very excited about. And one more point, can I make?
Of course.
So my final point is, as we worked with communities, and also the research and literature shows, individuals, people, the poorest spend 65% of their expenditure in the private sector. And the survey that the Lancet Commission did in 2023, which is the backbone, if I may say, of the Lancet Commission report, says 75% of people want an accountable public health system, and the fact that 40% people go below the poverty line because of catastrophic expenses in the private sector is a good reason to reimagine India's public health.
Thank you, Poonam. We are talking about citizens, and we have citizens here. We will be coming to you for questions shortly, but before, and Vikram, I'm going to come to you in a minute to talk a little more about the report, but let me first turn to Tarun. Tarun, we've now heard about the private sector from someone who is sitting as a civil society activist. You are someone who looks at this seriously. You've had a very key role in this commission work, so please talk about you as a business school professor, the issues you look at and how they played into the report.
Thank you, Hitesh, and thank you all for being here early in the morning. When we started this commission, it was a very unlikely partnership between Vikram and myself. I'm very interested in social determinants of well-being, and in particular in harnessing the power of the private sector to contribute to the social good. In my own thinking, I resist preconceptions of whether public and private sector is better or worse, and try to go where the evidence is, and try to think about ways in which different sectors of society can come together. I really liked, Richard, your phrase from John Rawls, realistic utopias. And in a sense, a lot of what we ended up doing with the commission, which really brought together very diverse groups of people in a way that we consciously tried to assemble in ways that prior commissions, and there have been lots of commissions in India on universal healthcare, approximations thereof, going back to the 1946 Boer Commission. Most of them have not had the effect that they intended to have. And Vikram and I had the hypothesis up front that this was because many concerned facets of society had not been included in the conversation. And therefore, as Naipaul said, India is a land of a million mutinies, and anybody could essentially exercise a veto over the implementation. So the entire architecture and genesis of this is to bring people in who have not been consulted before, whether they are community activists, frontline workers, the citizens themselves, hence the title of the commission, the Lancet Citizens Commission for Universal Healthcare, Reimagining Universal Healthcare, technologists, insurance companies, not to pass judgment on anybody ahead of time as to whether they had a point of view on this, and to embrace the differences, to try to be a little bit more realistic, to prevent the ex post vetoes that have typically bedeviled these efforts in the past. So just as a simple example, we had a lot of technologists. India's vaunted prowess in technology is well known to this room. We've had the India Stack. We had Aadhaar before. We had vaccine capabilities. We had the space program. And somehow we've never brought that into conversation with the front lines of the health system, until I think we were the first to potentially try to do that in a serious way. Now just take technology and take a very simple but very profound problem that the patient and the physician provider of healthcare experience, which is there is very little continuity of care. Vikram mentioned his mother's diabetes. I think every second person in my family probably has diabetes, whether they know it or not, in some ways, or are predisposed to it, given the genetic predisposition that we have from this part of the world, particularly males. Diabetes requires continuous care. It requires community care. It requires primary physicians. It requires endocrinologists. It requires medical devices. It requires sophisticated insurance plans. And God forbid, it requires end-stage care, renal failure, what have you. But there is very limited continuity of care. In our report, we advance, just as an example, this idea of an integrated care system, integrated delivery system, IDS. And our imagination, purely illustratively, is to say that around India, a public sector secondary hospital should be the nodal construct behind an integrated delivery system. So imagine that. There's a public sector hospital. Very few people in this room would go to one currently, but imagine, we are imagining realistic utopias. And that secondary hospital would maintain links both with a network of pre-screened and certified primary providers, whether they're in the public or private sector, as well as with tertiary care providers, many of whom currently are in the private sector. By the way, for the most part, outpatient care today in India is provided by the private sector, whether one likes it or not. And a goodly proportion of inpatient care is provided by the private sector, whether one likes it or not. So this integrated delivery system stitches together and delivers continuity of care. And the reason we're able to advance this is that this comes out from conversations between physicians, community health workers, private sector entrepreneurs, regulators, insurance companies, experts, medical device companies, pharma companies. Everybody has to be present around the table to do this. And technology is what stitches it together, and that's where India's prowess in technology can come together. Because without that, for a nation of 1.4 billion plus people, it's almost impossible to deliver. So hopefully in that vignette, Hitesh, you see a little bit of what different sectors of all of us have, I think, I hope, congenially tried to advance this conversation.
So I think that gives us a basic overview. I'd like to come to each of you maybe for a little bit of a lightning round before we open it up to the audience. And Vikram, do you want to start by taking us a little deeper into the report? It's quite, I waved it around before. It'll be fully openly published soon, so you can take a look at it. It comes in a country which has a multi-thousand-year tradition of healthcare, as we know. And it's a unique look at the present moment. Do you want to take us a little bit into it and give us a few takeaways?
So maybe I'll just focus on what were the challenges that we identified. And, I wanted to just say that I want to take a historical perspective on this. Tarun mentioned the Bohr Committee, which was in 1945, around the time we were about to get our independence from Britain. Ironically, in Britain, actually, there was another committee that was also operating, the Beveridge Committee, and maybe Richard can speak more to that. Ironically, in both these nations, which were connected at the time by the single crown, there were these committees to reform the healthcare system, because in both countries, the healthcare systems were largely privatized. We forget that most of India's healthcare system before 1945 was a private healthcare system, and completely in the informal sector, a lot of it. And in Britain, in fact, only the poor went to the public system. See what happened. In 1947, Britain adopted the recommendations of the Beveridge Committee, which recommended a nationalized healthcare system with strong public guarantees, public taxpayer funded, etc. But India, with exactly the same recommendations, could not do that because, of course, we were completely impoverished by the British. And so what then the government of the day did was to do a much more selective investment in the public system, because we had no doctors, we had no nurses, we had no manufacturing capability, and so on. Fast forward to 2020, at the start of the pandemic. I've already mentioned to you, the tragedy that happened in this country. But there is also a positive story. We demonstrated through a combination of the incredible, formidable resource, the ASHA, for example, a humble community health worker, extending all the way through to our pharmaceutical and vaccine manufacturing capability, and the government's commitment to build a technology platform, the CoWIN platform, which today, in fact, has become the infrastructure for perhaps the world's largest digital public infrastructure for health. We were able to carry out the most unprecedented vaccination campaign. So what I'm trying to say here is that India of 2020 is in 2026 now, is an India which is totally different from 1947. And in our commission, we demonstrate that therefore, this is a historical inflection point, literally to turn the clock back to the Bohr Committee and say, is this the moment for this government or any government to actually grasp the essence of a publicly controlled, a publicly provided, with a clearly defined role for the private sector, but one where each of us can go to a physician and know that we will get the best quality of care that is tailored to what we need rather than what we sometimes worry about, care that is often completely driven by commercial interests, either of the hospital or the doctor. And I'll just finish by saying, we have so much data that we've collected. Please do look at the report on the 21st of January. It is public and open access. We carried out the largest survey ever conducted in this country, 50,000 households from around India, that gave us rich primary data on the experience and expectations of India's people from the healthcare system. And the single biggest message that comes from that, as well as from a lot of other data, is the question of quality that I touched on earlier. And I'll end by just one startling piece of data. This is truly the most shocking piece of data, that it's not our original data, it comes from actually the Economic Survey of India and other work that the Lancet has published in recent years. Here's the figure. More people will die in India because they went to a clinic and got poor quality care than because they did not go to the clinic at all. This is a gigantic shift from 1947. We have, as we saw earlier, almost 100% access to care, whether it's public or private. But unfortunately, the quality of that care isn't what we deserve.
Gosh, that's a very sobering set of facts, Vikram. And yet, as you point out, the vaccination rates in India after COVID were in fact, I think percentile-wise, India did better than the US in terms of the percentage of the population vaccinated. Richard, I was going to go to you, but given what Vikram is saying, Poonam, may I go to you first and say, Vikram has both given us something of a historical look and the task ahead of us. So what are the partnerships? How is it that you envision the work going forward?
So our work begins now with the publishing of the report. We need to not just identify gaps, and also we didn't start the commission thinking India doesn't have a public health system, policies, programs. We're well aware of the huge infrastructure that has been built in the public health since independence. So what we are really looking at is to strengthen from our perspective, yes. And the work we take forward is advocacy for the recommendations which have been so thoughtfully, with evidence arrived at by the Lancet Commission, work with the government on not just strengthening gaps, but bringing the citizen, it's the guiding principles of the reimagined public health, citizen-centered health system. The idea is to shift from facility-centric, reactive, fragmented systems to coordinated, citizen-centered systems, and where decentralized governance guides a lot of the, not just the implementation, but the planning. So all this will require, as I said earlier, there are 5,500 committees that need to be operationalized, democratized, where panchayats, ashas, frontline health workers will participate, where women have, gender is key here, where women, the system fails them because 10% of the women only can decide have the freedom to decide if they can go to a health facility, get married, have a child. So all of this in terms of moving empowerment, we mix empowerment with agency, and I think in the commission we are very clear going forward on our advocacy. Empowerment is when people are provided the services, opportunities, but agency is when people are able to act. And the citizens' engagement, that's where we want to, not just women, but all citizens to be able to participate. Otherwise, we will fail not just the women, but we'll fail the people, and there'll be the largest number of deaths. We can do something about it, and so advocacy, technical support to the government, community holding government accountable is going to be the way forward.
Thank you.
Can I just say something to that?
Yes, of course.
Because the last thing that Poonam said is really important. How many of us feel that we can hold our health system accountable? I can guarantee that almost none of us can actually say that. The only accountability system in India today is to go to a court. Yes. And let me be honest, as a physician, there is a kind of we have a compact that we will never ever speak out against one of our fellow professionals. There's a word for this, I'm forgetting what it is.
An omerta.
Yeah, so the honest truth is we are all absolutely held hostage by an asymmetry of knowledge between the medical system and the rest of us, and that is the current state of affairs.
Richard, I saw you taking notes, so I'm sure there's some fascinating thoughts. If you need a prompt, let me say, you in your position, and Vikram, Richard has also been a practicing doctor and an academic. You have a global view. So how are you reacting to what you're hearing? And from that global point of view also, how does the report resonate with you?
Thanks, Hitesh. I've got a slight deja vu feeling at the moment because in 2011, Vikram and I, led by a great friend and colleague, Professor K. Srinath Reddy, who was director of the Public Health Foundation of India, we were standing outside the residence of Prime Minister Manmohan Singh at the time, And we knew that the Prime Minister, a greatly respected economist, technocrat, responded very well to complex evidence. And so Vikram and colleagues had written 7 densely technical and impenetrable papers in the Lancet, which we presented to Prime Minister Singh, who was delighted to receive them. And nothing happened as a result of presenting that series. And not entirely his fault. His first term, of course, the National Rural Health Mission had been a great success. The economy had been turbocharged. It was a great opportunity. But his second term ran into problems. And it wasn't the best moment politically to present that series. The difference between this commission and that series is this one word, citizen. And it is worth reflecting on what do we mean by the word citizen. And it's a question that perhaps we should ask ourselves here. What is the role of the citizen in a democracy such as India? There are a set of responsibilities, duties, as well as rights that are accorded to the citizen. And if one looks at the history of any transformation in society, those transformations have demanded a population that has agitated, that has campaigned, that has protested, that has demonstrated for change. And so what I'm hoping this commission can do, it's a big ask, but can it be part of igniting a social movement for health in India to create that demand for transformation? We can't do it on our own, but we can ignite something much bigger than ourselves. And there's a crucial partner here. And I wonder about the responsibility of that partner and whether that partner has discharged its responsibility well so far. And that is the media. Have the media truly told the story of this country and revealed the unacceptable inequalities in this country? Have they brought those unacceptable inequalities, the exile of the poor in this great nation, have they brought those communities to the attention of those with political power in a way that holds those with power accountable? And as an observer, a humble observer, I question whether they have. So, creating that demand from the public, partnering with the media, creating systems of accountability to hold those with power accountable for their decisions, that's what I'm hoping this commission can begin to achieve. We are not going away. The publication of this commission is not the end of the process. It is the end of the beginning of a process. And we will come back again and again and again in partnership with this panel and building a larger coalition of the willing to make sure that the vision, this realistic utopia embedded in this commission, is fully realized in the years to come. So join us in this mission.
So, thank you. Tarun and maybe Vikram, just some quick last thoughts, and then I want to open to the audience. And Tarun, from you especially, because you look at how we approach big, serious problems.
So, thank you, Hitesh. I just want to pick up on something that I think both Poonam and Richard just said, which is this is the end of the beginning, to use your memorable phrase. I'm an academic, primarily, an entrepreneur laterally, but primarily an academic. And so I think about continuous learning. And one of the things that our health system has not done is learn. It certainly hasn't made any explicit attempt to learn, nor is there really an implicit attempt to learn, as far as I can tell, at least as an outsider looking in. Now, I lived my professional life in a healthcare mecca in Cambridge, Massachusetts, surrounded by the institution that employs Vikram, Harvard Medical School, surrounded by biotechnology institutes par excellence at MIT and various labs. And there is an innovation coming out for healthcare every few days, something or the other, from the very little thing to the very large thing. Now, that's at one end of the extreme that we have. But we can have innovation not just in complicated scientific artifacts, if you will, or drug discovery. We can have innovation in processes, in the ways in which we effectuate governance systems. And on all those dimensions, there is so much room for continuous innovation and learning. That's why we conclude our report, our Lancet Commission report, with an exhortation to saying that this should really be a learning system in some ways. Now, that's another idealistic statement. We are, after all, in the business, Richard, of realistic utopias, as you pointed out. And that's my utopia, is that we all participate in this citizen's journey to find incrementally better ways every day to do the most fundamental thing of us all, which is to keep us all healthy in some ways.
Thank you. We have people with microphones in the audience, but while people are lining up, Vikram, did you have a quick final thought about the future and where we go from here?
Well, I'm just gonna follow on from what Tarun said. Tarun rightly said I work at Harvard Medical School, but I've been working there about the last 8 years now. Prior to that, I worked in the NHS in Britain, and of course, I've lived most of my life in India. I can say one thing, the kind of healthcare system we don't want is the American healthcare system. And I fear that it's the healthcare system that we are blindly walking into, a healthcare system that is unaffordable. It's a healthcare system that is deeply, deeply driven by the interests of physicians and hospitals rather than communities. And I think to that extent, what is remarkable about India is that right from 1947, every government has committed to produce a citizen-driven healthcare system. And on the question of innovation, I think we can be justly proud in this country that perhaps the single most transformative innovation that's come out of India is the community health worker. If today the community health worker is being embraced in the United States, it is the one Indian innovation in healthcare that has been exported and embraced around the world.
Thank you. So we're going to go to that lady in the back. We'll get to a few questions, but I do want the audience to acknowledge the truth of how I started. 4 extraordinary people, 1 simpleton, and I told you it was a good plan, and it's worked. Please.
Hello. I'm a recently graduated surgeon, and I'm interested in working in rural healthcare and bridging the urban healthcare divide. I've been working in rural NGOs. I wanted to ask whether you still feel there's a role for NGOs working in rural areas, considering most of the conversation has been around the public sector and private sector.
I love your question. Yes, there's a huge need. You know, there's a 40% deficit of doctors in the public health system. And that's a huge challenge people like you can fill. And I do hope you won't go anywhere but the public health system. And it's not just the NGO sector, but within the public health system too. But NGOs, there are NGOs across the country, and Rajasthan has some of the most lively and robust NGOs working on health. So do see me.
Thank you. We'll go to the person with the glasses there, yes?
Hi, I just wanted to say that I actually helped research some of the Lancet report under Sandhya Venkateshwaran, so I'm quite familiar with the Bihar sections of the report, and so it might be, I'm trying not to ask a technical question, and my question is, we saw a lot of the state ceding a lot of ground to private healthcare. How do we kind of build up the state system in a way that it is actually aspirational to go to a state facility versus a privatized healthcare? Because while we want to fight the American model, I see the American model entering even the states like Bihar, where privatization is becoming more and more the norm and aspirational for citizens to actually go to, despite the level of care and the aesthetics of care perhaps being the exact same. So they're not perhaps getting better care, but they're paying more for that same care.
Thank you.
So let me speak to that. Thank you for your question. I think it's you remind us to mention the extraordinary variation in the way healthcare has played out in India's states. There's some very interesting analyses in the report that you may yourself remember, showing that on average we are spending across the country more than is necessary to deliver a basic package of universal healthcare. So in a sense, in a very basic, simplistic sense, it's not the case that it's lack of money that's the primary problem. It would be nice to be able to spend more, and I hope we get there, and I think we will get there. But more important than that is, again, going back to my last comment about a learning system, is learning from variation across the states. And one of the innovations I like that one of our colleagues from Bangalore came up with in the report is this construction of a universal healthcare index, which is a beautiful idea, very simple, and of course not without its flaws, as any index is, but it allows you to shine a light on variation. And then you can ask whether there's something sensible to learn from that variation. So my abstract answer to your particular question, if I may, is that if we have those data continuously published, and we emphasize transparency and data a lot in the report, there's room to improve dramatically.
Can I just maybe
Absolutely.
also ask Richard to step in here? It's important for us not to demonize the private sector. Maybe that's perhaps maybe what people might be taking away from some of the conversations we're having here. That's not the intent at all. The private sector, in fact, does play a very crucial role in India. Most of us actually in this demographic use the private sector. The question is about how can the private sector be shaped to play the role of a public good. And I wanted to ask Richard, because Richard, you've been very aware of health systems in other parts of the world, including in Europe in particular. How does the private sector get, what kind of roles do they play in universal healthcare?
Can I add a question to you, Richard? Just that one sentence, and that is, the problem in India is that the private sector is totally unregulated. So what about also commenting on regulation of the private sector without bringing license Raj?
Okay, nice, simple question. First of all, there's no such thing as the private sector. What we call the private sector is an extremely complex, fragmented array of providers. And to conflate all of those fragmentations into one entity called the private sector is a huge mistake. Parts of that private sector will be delivering, and I put it modestly, suboptimal care. Other parts of that private sector will be delivering care that is actually supply-induced demand. So we want to be very careful about our definitions. I trained in the National Health Service as a medic, and I was 100% committed to the idea of a public health system and vehemently against the private sector. But one of the things I've had to concede in my far too long life is that in any country, if you're going to engage in a struggle for universal health coverage, there has to be an alliance between a public sector and a private sector. You will not achieve universal health coverage in a country without an accommodation between those two sectors. And that is what this commission very, very clearly lays out the evidence to support. How do we build that alliance to create an equitable, high-quality health system? It requires partnership between the two. And I will challenge you to show me any country in the world that has achieved universal health coverage that has not had an alliance between the public and the private sector.
Thank you. So we are actually out of time. I'm going to break the rules. I need someone with a short question, a brief question. Why don't you go to that lady over there? So I can't see over there. Yes. Brief question.
No, I don't have a question, but I think Poonam touched the point that I wanted to make was on the, I hope the report mentions about the regulatory mechanisms within private health sector, and also the, who is ensuring that the bridge between the public health, the private and the public hospital systems are actually managed, because we have something called a EWS, where someone who's economically challenged can actually access private health systems. But I saw the disparity very recently where someone was got to emergency and was, because he didn't have the documents that are necessary, was asked to leave, even though the person he knew would die once taken out of that emergency. So those were the points that I wanted to make. And the third is redressal, which needs to be very strong across systems, whether it's public or private. And the last point is that when you say a utopian health system, I say Herculean to add that in a country which has such huge disparities in health system. So those were the points.
Thank you, Madam. Madam, I should scold you because you neither asked a question nor was it brief. However, everything you said was of great import. Any last summary thoughts from here before we close? Poonam.
So very quickly, redressal mechanisms to be put in place and implemented is a key recommendation from the citizens' point of view in the report, and also citizens as active rights holders. And finally, knowing their entitlement is a key for the Citizens Commission recommendation. Thank you.
And I might just add one more thing on the matter of citizens. You know, we live in a democracy, and you'd think that the government, the political party of the day, will respond to what citizens want. And it is true that health has historically been very low on what citizens expect from the government, because we never got health.
Exactly.
However, that is changing. And all of us need to just look at the way political parties, their manifestos, and we did that in the commission, especially for the last national election, but also at some of the state elections. It is rare to see a manifesto that doesn't highlight near the top, along with employment, health.
Yes.
And that is a signal that there is a change in the way that people in this country view health as a fundamental right. And when that happens, I think government will respond.
Thank you. So, thank you very much. Because someone mentioned, I think the lady over there, Herculean task, I just want to say, what we have is a Herculean task. What we've laid out here is a Herculean task. Of course, because I always think in poetry, I immediately thought of that beautiful line from Mir. Mir, ishq ek bhari patthar hai, kab se tujh natavan se uthta hai. Mir, love is a heavy stone. Since when can a weakling like you lift it? But that is the human condition, and there's nothing to do but try to lift the stone of love, or in this case, the stone of healthcare. I want to thank all of my colleagues, Poonam Muttreja, Vikram Patel, Tarun Khanna, Richard Horton. Again, I want to thank our wonderful hosts, the extraordinary festival organizers, and I want to thank all of you. It's been a pleasure speaking with you.